Well, good morning. I think we're at time, a couple of minutes beyond. We'll get going here. We're going to talk this morning about, what have I titled this? Accessibility in medical issues, healthcare disparity, and widening the welcome. Going to cover a few areas, hopefully not too overburdensome. It is Saturday morning, I'm well aware. There are handouts available in the Dropbox for the conference, a PowerPoint, if you would like to refer to that. So recently I was visiting with a family and a patient who was facing critical and end-of-life issues. I'm a hospital chaplain in the Columbus, Ohio area. I work for a faith-based hospital, Methodist-based. I don't hold that against them. And I have the privilege of working extensively in intensive care unit with lots of folk. So Adam, not his real name, was a 40-year-old person with multiple medical issues who had had a recent cardiac arrest, resuscitation, a second cardiac arrest, and a second resuscitation, and was on life support, mechanical ventilation, blood pressure medications, etc. Adam was also a person with developmental disabilities who at 40 years old, the medical team, while discussing his case, said, well, he has lived a good life to have lived to 40 years old. What was striking was that if the patient were different, a patient with a job in an executive or leadership capability for a corporation who was 40 years old and what we term as able, the conversation would be tremendously different in terms of what do we need to do for this person. But at 40 years old, Adam was talked about as though he had already lived a good life in terms of it was over, aside from his medical condition, which may or may not have been reversible. In other words, the conversation is different depending on a person's ability status in the medical community. A few examples. At age 19, Terry Lincoln was in a coma from an automobile accident when doctors repeatedly urged her parents to withdraw life support and spare her a future life with serious disability. When she awoke, they approached her with a promise they could make her dying comfortable. She and her family resisted, and over a decade later, she is now raising her own young daughter and happily living using a motorized wheelchair and receiving daily personal care services. At one university hospital, there were allegations that a doctor attempted to unduly influence the family of a 72-year-old patient with developmental disability to deny that patient life-sustaining treatment. The family reported that the patient's doctor informed them that the patient would have a very poor quality of life and that life-sustaining medical treatment should no longer be used. Initially, the family agreed with the plan, but when the patient woke the next morning and requested to eat, the family changed their minds. The family requested the treatment and nutrition be resumed, but the doctor resisted. They received resistance from the doctor, who eventually relented and began treatment and sent the patient back to live at a nursing home to recuperate. So to reverse that became very difficult for the family. Right now, somewhere in America, parents or guardians are sitting down with a doctor to discuss either withholding life-sustaining medical treatment in situations where there is no terminal disease, or perhaps deciding on involuntary sterilization for a child with disabilities, or deciding about what to do with genetic testing results. In one case, stunningly illustrating assumptions made about burdensome people, quote unquote. A jury in Oregon awarded parents $3 million because their child was born with Down syndrome after prenatal testing failed to identify the disability because it was called a wrongful birth. Wrongful birth. High level, just a quick glimpse into some scenarios, some vignettes, some people, to hopefully begin to illustrate, set the groundwork around some disparity that we don't often see and we very rarely talk about. I was going to give you a brief history of disparity. I'm thankful for Brett's presentation this morning. He talked quite a bit about some of the history. There is an extensive history in the Americans with Disabilities Act around how persons with disabilities have encountered health care, institutionalized and experiments, eugenics, euthanasia, camps in Germany during World War II with extermination. The medical care has always had not even necessarily a separate but equal, but a separate and unequal provision to it. I'm going to move into, I won't go any further really into a brief history of disparity. I would encourage you to read into some of the history, but also know that some of those issues continue on, such as eugenics, involuntary sterilizations. As a matter of fact, I received an email the other day. The Hastings Center for Bioethics just announced that they received a $1.1 million grant for a new study into prenatal genetic testing. And to determine in what cases it's okay, what cases it's not, to, quote, set the boundaries as to what's acceptable for prenatal genetic testing as we go forward. Not to say that it ought not be done, but to set boundaries around it. We could ask how long those boundaries will last before we have another study and widen those boundaries. I'm going to talk for a moment about over-medicalization. It's a term you may or may not have heard. Over-medicalization is a problem the disability community should be justifiably concerned about. You might say it's over-pathologization. That's a great term for you there, too, because it strips persons of their social context so that persons come to be understood only in terms of a prevailing biomedical diagnosis or condition. You hear this in the hospital a lot. You know, you've got the knee in room 23 or the MRDD over in room 2. Stripped of social context and labeled by biomedical diagnosis or condition. I think there's two problems with over-medicalization. First, and perhaps more common, is the way this plays out is to over-medicalize disability. But there's also the possibility, I think, of over-medicalizing health. As we move forward with the Affordable Care Act, with Medicare regulations, with well-care programs, well health programs are a great example. Continued over-medicalization or preferred or optimal health runs the risk of broadening the gap between persons with abilities and persons with disabilities, of what is understood to be healthy, and increases the stigma associated with the healthcare disparity. Does that all kind of make sense? You all follow that? The hush falls upon the crowd.
Exactly. Can you elaborate on that, please, Gunnar?
In terms of what question do you have there, Linda?
You just asked if we understood the medical.
How I'm using that over-medicalization to maybe, at the risk of a slippery slope, saying that over-medicalization and the preference that we place on well care and defining what healthy is can broaden the disparity of what unhealthy is in terms of how disabilities are viewed.
Fine.
It's quite all right.
I'm fine.
He's practicing his entrances.
Yes. My grand entrance.
That was a grand entrance.
Yes. I believe I got called up. Here I go. Sorry about that.
Can you address in law school in Chicago we had a lecture, 3-day lecture on the right side, medical stuff, and I'm trying to put my head, trying to wrap myself around that whole subject when it comes to drugs and medication. The attitude is it's too damn much money for the insurance. Those that when we go to law, that person to become medicated, and slowly the person may die because of it. They know that. How do we deal with that?
That's a great question, Ben, around death with dignity and physician-aided death, Medicare, medications, etc. I do want to get to that in a little bit, kind of more as a discussion for the group rather than any necessary presentation on that. Does that make sense?
Thank you.
But I do want to allow time for that. There's a couple things I want to point out that may help us frame and think about some of the other situations that may feed into prevailing attitudes. Is that helpful?
Sure. Thank you.
Okay.
I asked another question.
Mhm.
I don't know if you're going to get to it or not, and if you don't, that's fine. But one thing that I've noticed in the medical model is insurance companies and stuff. The phrase I use is they'll pay to get you well, but not to keep you healthy. Like, for example, with my arthritis, there's a lot of stuff like physical therapy and massage and stuff that doesn't qualify under insurance. That say I got a neck massage once a month even, right? That would loosen me up, make me more mobile, make me a more productive member of society, make me less likely to be on Social Security, blah, 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 blah. But that's an alternative therapy, and that's too much money, so we're not going to do that. Instead, they'll pump me full of drugs that have side effects that make me sicker anyway. So I was just curious if that's something that might be addressed. How they want you, if you get in a car accident, they'll pay to fix it, but they'll only put you back to your level of function. They won't, if you have a chronic condition, they won't pay to keep that. Does that make sense?
Mm-hmm. Mm-hmm.
I don't know if I worded that right.
It does make sense that the healthcare system is structured to return you to what was, quote, your baseline before whatever event you just encountered. And that there's not a lot of improvement.
Yeah.
There is some in well care programs, if you have private payer insurance, they may have some programs, but government funded is very basic, yes. I'm going to talk about, before we get to death with dignity issues, two prevailing kind of high-level things. I'm going to talk about organ transplantation listing disparity, and I'm talking about pandemic response planning disparity. Okay. And then we'll get to death with dignity issues. So there's lots of issues, and you have to make choices when you have an hour and a half as to what you're gonna pick. So that's kind of the direction we're going to move, if that helps. So how does over-medicalization, how do these issues begin to come around? You can make a case that there's limited knowledge and training around disabilities. We've talked about that. We have the prevailing medical model within our culture, and that affects how we train physicians, social workers, etc. in school as they're going through. Funny, Kaiser Permanente in California polled providers of adult primary care, and they were asked about their ability to recognize autism, for example, their knowledge of the disorder, their comfort level in treating those with the condition, and their need for training and resources. And nearly all the providers said they would explore the possibility of autism in patients with limited eye contact. In other words, the providers would explore the possibility of autism with persons who looked like they had autism. Most underreported the number of people on the spectrum who actually had autism that were under their care. In more thorough follow-up interviews with 9 primary care physicians, researchers found the majority had received limited or no autism training in medical school or during their residencies. All the providers indicated a need for more education, said they'd like to see improvements in the transition from pediatric care providers to adult medicine for those on the spectrum. Another little interesting piece, a 2012 study found that more than 50% of adults and persons with serious and persistent, quote, disabilities reported good or excellent health care related quality of life.
How many again?
More than 50% of adults with disabilities self-reported that they have an excellent health care related quality of life, which others said was less than optimal quality of life. I throw that out there because there's a term associated with it that you may want to keep in mind. It's called the disability paradox. Okay, the paradox that persons with disabilities consistently self-identify with a higher health care quality of life than persons with abilities will ascribe to them as having. Okay? So the view is that persons without disabilities view the quality of life question as persons with disabilities have a low quality of life, but persons with disabilities don't feel that way necessarily. Ben, that's an important piece I wanted to mention as we approach the death with dignity conversation. We talk about quality of life as a big issue there, and I want to raise the disability paradox around healthcare quality of life.
The other statistic was the very high percentage of people that wanted to die.
Mm-hmm.
When you look at that whole statistically, I do not personally believe that because I did not see the raw data because he was not given to me because he thought I was born again in prison and he told me to shut up in class that I paid $500 for 3 days. He told me to shut up because I was born again in prison. But he said it came out of Brooklyn, California, and he didn't tell me the data. So I don't know.
Yeah,
It's confusing.
it is very complex and confusing. Yeah. So let's talk about pandemic response planning. How many of you have an idea what a pandemic might be? Pandemic.
The swine flu? Is
Hmm?
that a pandemic? When the swine flu came out?
The swine flu, severe acute respiratory syndrome, or SARS, that was big overseas. You remember seeing pictures of everybody wearing masks to protect themselves.
Ebola.
Ebola is the most recent threat for a pandemic. H1N1 was substantial in that it pushed us to really begin to formulate pandemic response plans to care for people should that event occur. Okay? So that we've started to generate plans as we think about how, of course, Ebola is a little different than a pandemic flu, but still, nonetheless, we have plans in place. So what are those plans? Who do they include? Who do they not include? How were they developed? I found a quote from a newspaper story, 2014 story from Africa. A person with a disability, Elijah White, expressed disappointment about the way disabled are being treated in terms of the Ebola prevention methods in the country. He says, quote, "I wonder why we are left out of the donations. Is it that we are living with disabilities and are not humans? Don't we have life? Or is it that we are not citizens and cannot be affected by the Ebola virus?" End quote, Elijah angrily asked. In a survey of many preparedness plans, it was revealed that no plans explicitly indicated whether they had systematically identified or included vulnerable groups in the planning process, or that they were even committed to identifying who the vulnerable groups were. It is noteworthy that countries were more likely to develop policies to protect or compensate those who may become disadvantaged by a pandemic than those who are likely to suffer disproportionately because they are already disadvantaged. That comes out of an article. There is a reading list, reference list on the, I almost said SharePoint, the Dropbox website for the conference. So during a pandemic, many patients may require mechanical ventilation as part of the course of treatment. Ventilators in the ICU. Small problem. There are millions and millions more people than there are ventilators. Guess what? We have to make decisions. When a pandemic hits and you have more people that need a ventilator than you have ventilators, you have to begin to make choices on resources. One article suggests that during such an event, extra autonomous decisions will need to be made to withhold treatment and withdraw mechanical ventilation from some patients who might still benefit in order to serve other patients. Who do we withdraw from? How do we decide who receives the mechanical ventilation? Highly lethal pandemic conditions justify a reordering of ethical imperatives, whereby substantial community benefit and commitments to fairness override, albeit reluctantly, important considerations of autonomy. So autonomy begins to be sacrificed in the event of a pandemic. Some of these cases of involuntary withdrawal of ventilation will be, in fact, involuntary treatment termination, which in otherwise times of normalcy would be unthinkable and more equivalent to euthanasia. It's a worst case scenario, but we have to ask if de facto euthanasia is possible in pandemic response planning. Who is at risk? Groups who have been historically underrepresented and vulnerable, including persons with disabilities. Indeed, given that the social welfare and healthcare systems in the United States reveal inconsistencies in the actual delivery of services that seemingly mark some identifiable populations as de facto less deserving of resources under baseline conditions, it is worthwhile to consider how these groups would fare in the event of a national medical emergency such as Ebola. Yes?
I know this is kind of off your topic, but doesn't that don't the elderly also fall under that category? Like if I'm 85 years old and they are going to give their limited resources, probably I'm going to also receive those limited, or not receive those limited resources.
Absolutely. Absolutely. Persons with dementia, persons who are retired, 70 years old, still active. When you have to choose between that person and the 40-year-old corporate executive,
Or the
who's going to get...
the 23-week premature trial. But those things happen, without a pandemic. Those things
Right.
happen in a socialized medicine. You make choices if you have your gallbladder out or wait 3 years.
So it's not... Yes?
I was just gonna share something I don't want to take, but you're talking about the pandemics and stuff. I have an immune deficiency as part of my dwarfism, and when the swine flu happened, I'm always supposed to get the regular flu shot first, like I was told. You sign up as soon as the flu shot comes out, you need it, you have to protect you. And when the swine flu shot came out, no one would give me a swine flu shot because they only had enough for pregnant women and children who were 3. And then they had all these commercials that were like saying things like, if you have a compromised immune system, if you're over the age of 75, you take these immunosuppressants. You must get yourself. And I ended up throwing the television remote going, I'm trying, damn it. Because I had called the local Center for Disease Control, like the Minnesota State. I called everybody I could think of. I called my old pediatrician. I called every single doctor. And they said, we can't do anything to help you.
What
It
did
was
you
scary.
say? I'm sorry.
She said that when the swine flu vaccination came out, persons with compromised immune systems, such as she has, were encouraged to get a flu shot. But she was not able to get one
Because they have limited resources.
because they were given to
Pregnant women and children under 3 first.
pregnant women and children under 3 first, and the quantity was not there for her to receive one. She couldn't find it, even though she was in the category that was recommended to receive one.
Terrible.
Okay?
Absolutely terrible.
Why?
Terrible.
Minnesota Pandemic Ethics Project. The Minnesota Pandemic Ethics Project gathered several panels which actually included persons with disabilities. One of the very few that anybody's able to find that names that they've included persons with disabilities in their planning. To assess ways to attend to socially vulnerable groups when planning for a severe pandemic. So here are some of the recommendations that the Minnesota Pandemic Ethics Project made. First is that a severe pandemic is not the appropriate time to seek to redress historical injustices in the healthcare system and society at large. It's before that. Okay? Improved access to resources in a severe pandemic in ways that protect against stigma and further marginalization and exacerbation of healthcare disparities within vulnerable populations. So work to decrease the disparities, and when the pandemic strikes, make sure that we're implementing care in ways that do not worsen the stigma that already exists. And then they went on to talk about identification of access barriers and strategize means of removal. For example, there needs to be plans in ethics, in pandemic plans, about where persons who use wheelchairs can safely and effectively access resources. Why? If you have 16,000 people flooding into the streets in a panic, are you going to be able to move your wheelchair around in the midst of 16,000 people?
How do they move it at the fair?
Are you going to be able to use yours in 16,000 people? So,
A lot of broken feet.
right.
A lot of broken feet.
So, as part of the plans, what about where persons who use wheelchairs can safely and effectively access care? How do they get there? How do they receive the care? And then another one, which I found, you were talking about Medicare, Medicaid, okay? So there's a pandemic, and they come on TV and they tell everybody, stock up. Get extra water, extra food, extra supplies, extra canned goods. Fill your pantries so that you can stay home when the pandemic hits or gets to your neighborhood, right? Medicaid requirements will not allow you to have extra resources. You can't stock up if you receive Medicaid. So the government says, stock up for the pandemic, but if you're on Medicaid, you can't. So there's automatically a disparity. How do we begin to, in advance, address policy changes so that pandemic response planning is more accessible? Okay, moving on, because I know we only have a short amount of time at an hour and a half. Organ transplant disparity. The reality of organ transplantation is that it is a life-altering, life-saving process. The other reality is that it is bounded by supply and demand. Okay? We might, as a church, say it's bounded by a theology of scarcity rather than a theology of abundance. Given the scarcity of available organs, transplant teams cannot list every person who needs one. Therefore, they use medical and psychosocial criteria for the decision as to who is included and who is excluded from the organ transplantation list. The governing agency for organ transplantation, UNOS, in the United States, affirmed that patients with disabilities should not be excluded, that the ADA should be followed, that everyone should have equal access to the wait list for organ transplantation. Sounds good, right? Sure. In a survey studying transplantation experiences of persons with neurodevelopmental disabilities, in which half of the patients were 18 years old or younger, investigators found that a transplant evaluation was not performed in nearly half of the cases where organ transplantation was suggested as an option. Another survey of adults asked transplant coordinators if and how a broad range of psychosocial criteria were used. Nearly 2 in 5, or 40%, of the transplant centers, quote, would have listed a patient had it not been for their neurodevelopmental disability, and a number of programs use neurodevelopmental disability by itself as a contraindication for being listed on the wait list.
Is it so that okay? That adds up. I remember reading something that I didn't know if it was a fact or a myth. Like if you have Down syndrome, you can't get a heart transplant.
It's highly possible. It's highly possible that the team that evaluates would either not evaluate or evaluate a person without Down syndrome in front of a person with Down syndrome.
I'm in Cerda right now because I work among the Indian population in South Dakota. The healthcare system is so piss poor. I'm working on the poorest reservation in the country, and it is unbelievable what they don't get and we get, and they can't get it because they don't count. It is unbelievable that we are a rich country and when we make decisions and favor the rich and the powerful people in the country and the poor people are left from the leftovers. That is unbelievable.
Yes, it is. It is very, very unbelievable. There's a quote from the Autism Project. Fundamentally, when physicians argue for denying transplants to persons with disabilities, they are saying that non-disabled lives are worth more than saving more than persons than those of disabled persons. I got lost there in the middle. Physicians are saying that the lives of persons with abilities are worth more than the lives of those without, or with disabilities, rather. There is no scientific evidence or compelling data to suggest that patients should not have access to organ transplantation. As a result, efforts to address discrimination against persons with intellectual or developmental disabilities in accessing organ transplantation must focus on discriminatory referral practices and the transplant center evaluation process. So we need to identify where that breakdown is and advocate on that level. Some of the recommendations offered are that states pass legislation explicitly clarifying legal protections against discrimination for persons with disabilities seeking organ transplants, and that the intellectual developmental disability community learn to effectively defend its interest in the bioethics realm as well. Consideration given to the establishment of infrastructure for advancing disability rights priorities in bioethics, not just in the church, not just in politics, but in bioethics as well. To consider tactics focused on influencing public policy and cultural and scientific discourses that precede and shape the actions of government and how that rolls down in terms of pandemic and organ transplant. So I promised ethical considerations. I've talked about some of those. Autonomy versus substitute autonomy, or somebody else making decisions for you. That there's a tension there when it comes to supply and demand, if you will. That if we allow for substituted decision making in emergency situations, it may become the norm and not reversed after the emergency is over. The principle of beneficence in ethics, to promote that which is good for society, would say that any patient who would derive benefit from a vaccine or a medical treatment or an organ transplant ought to be considered for those and ought to receive those. However, up against that, we have resources, stewardship of resources, scarcity of resources, which brings distributive justice into play. Fair, equitable, and appropriate distribution determined by justified norms that structure the terms of social cooperation and govern the rationing of scarce resources. Transplant and pandemic teams need to be good stewards of resources and also need to distinguish who receives the limited resources that they have. But who influences those and who influences the distributive justice conversation? And our good friend utilitarianism. The needs of the many outweigh the needs of the few. We have to weigh that in. There are, as you heard this morning, ethicists like Peter Singer, who still have a very prominent voice in our culture, talking about utilitarianism, the greatest good for the greatest number. The problem is that often leads to a priority of persons with abilities over persons with disabilities, and a preference for those who will be independent over those who will need assistance. Utilitarianism. Considered is best use of resources and lower priority for those who will be a, quote, drain on resources. How are we doing on time?
You were picking me off.
11:14. Hey, 45 minutes. Good. So we'll move into, and I want you to hold in mind some of the disparities that have been thought about with organ transplantation listing, with pandemic response. And then now let's talk about physician-aided death, death with dignity, whatever term we want to use, there are many. 2014, this issue really came back in front of us with Brittany Maynard, who lived in California and moved to Oregon to avail herself of the death with dignity law.
I watched all of her interviews. Her interviews were really interesting. I watched the case very, very closely.
Uh-huh.
And she was just marvelous. Her attitude, it was just marvelous.
Okay.
But I'm not too sure I really believe in that. I'm on that border.
It's a very difficult, complex issue to think about. It really is. We've addressed it in the United Church of Christ, but we haven't completed our conversation. We haven't actually, in the United Church of Christ, really reported back to the General Synod about our conversation. General Synod 26 engaged the topic. The result was a resolution of witness directed to study the issue, with a report to General Synod 27 for further consideration and action. In advance of General Synod 27, Central Atlantic Conference submitted a resolution of witness titled In Support of Physician Assistance in Dying, which the Executive Council recommended to the study group formed by GS 26. And it never went to the floor. Justice and Witness Ministries produced the resource Faithfully Facing Dying, a Lenten study guide on critical issues and decisions for members of the United Church of Christ. How many of you have seen that resource? One hand gets raised in the room for the benefit of the recording. Both resolutions were contained within the study guide that nobody's seen.
Hey.
Except for Kelly. Along with position papers, both in favor and opposed. Position papers on both sides of the issue were contained in the study guide. To date, no further action has been engaged by General Synod. So,
where are we in the General Synods? What one was this? I mean,
We
how
just
far
had
are we?
30.
We just had 30.
Okay, that's what I recall.
So at 2 years apiece, to go back 4 General Synods, 8 years ago,
Got it. No, that was what I wanted to.
we began to look at the issue. 6 years ago, we were supposed to report back but didn't, and created a study guide, and we haven't done anything in 8 years. Now, some of that we can, General Synod can only address so much. I give them that.
Is the study guide on the bibliography you said?
The study guide, I don't remember if I had it on the bibliography. It is on the UCC website. It's available.
You can just search for it on the website, the UCC website.
Yeah.
It's fine.
Faithfully Facing Dying.
Okay, thank you.
So September 11th, 2015, last week. California lawmakers approved a bill, and it was signed into law, allowing physician-assisted suicide for terminally ill patients. The bill, modeled after Oregon's, would allow mentally competent patients to request a prescription to end their lives following confirmation by 2 doctors that the patients only had 6 months to live. Present at the signing were Brittany Maynard's parents. Okay? I take that back. I haven't followed this week to find out whether Governor Jerry Brown signed the bill into law, but it is on his desk. So physician-aided suicide or death with dignity, physician-aided death, medically aided death, whatever term you wish to use. Now there are laws in Washington, Montana, Vermont, Oregon. In the position paper opposing physician-aided death in the study guide, Faithfully Facing Dying, Denise Carruth offered the following: activists in the disability rights movement are strong opponents of suicide. We believe it is largely based on fear and the erroneous premise that living with a disability, in this case a disabling terminal illness that causes dependence on others, the loss of dignity, the loss of autonomy, is a fate worse than death. She also offered, regardless of their disabilities or limitations, no one should feel that they have to die to have dignity, to maintain their autonomy, or because they do not want to be a burden on others. Bradley Williams, the president of Montanans Against Suicide, argues that medical aid in dying would lead to family members ridding themselves of old and infirm relatives against their will. Allied with him are several disability organizations, and you can look up some of these, like Not Dead Yet.
But that's not what the statistics in Oregon are showing.
Correct, that's what I want to talk about. I want to open it up, okay?
Sorry, I'm very passionate on the topic.
Yes.
Coming from there.
Yes.
It's been a part of our family since '97. My husband's an oncologist. The Attorney General of the United States accused all physicians in Oregon who had ever given permission to a patient of murder. And all of those doctors' actions were watched constantly.
Yeah.
Sorry to interrupt, it's just, I think what people think it's about and what it is about, or the results are two very different things.
Mm-hmm.
There's a lot of safeguards in the law that many people are not aware of, in that it also requires a psychiatric evaluation to ensure the patient isn't just depressed or facing a psychiatric issue. It takes 2 physicians to evaluate the patient and the life expectancy or quality of life. Many of the patients who've come forward are dealing with pain that medicine cannot fix or eliminate. Significant discomfort.
There is a constant option too of opting out, even though you asked for it earlier. You retain.
Yes, the law states you have to be competent. You cannot tell your physician when you have 6 months to go, this is what I want to do when the time comes. And the physician will do it even if you are not cognizant. That is not possible. The patient has to be cognizant at the time they request it. There's a 3-week waiting period, during which time the patient can change their mind. Once the waiting period is over, it takes 5 days to fill it, just almost as an added thing. Many of those who receive the prescription never use it. It's become a crutch to know that I can end this if and when I want. The benefit of the law is that it has increased end-of-life care, improved end-of-life care, because it turned out most people were afraid of the pain it would entail.
So it's improved palliative care programs?
Significantly. And among the medical community in Oregon, Brittany's case was an abuse of the system. That it was not a legitimate request. Interestingly enough, my husband and others feel that not everyone who requests it should be given the request. And Bob wouldn't give it to each who asked. Some of the ethical choices he made were when a single mom diagnosed with breast cancer requested it. She told him that if he would not prescribe it, her alternative was to use her shotgun in the shed. And my husband said if he were one of her 2 sons, he would not want to spend his life remembering finding his mother like that in a shed. That it would be better to have mom and the children talk through what mom wanted to do and why. So, in Oregon, it's not associated with disability at all. It's more pain related or terminal illness. As a hospice worker, we are required to reconcile death with dignity in our work, because we have to face the potential of being asked by the patient for the prescription, to advocate for their using it. And as a minister, that took thought, because we all talk about dying in God's time, and it's God who determines it, and not us. So for me, it's a case of, I finally concluded it was not my death. I am not able to put myself in a dying person's shoes because I haven't experienced what they're experiencing. How am I to judge how they feel about their level of pain? And therefore, throughout the Bible, God says, you are not to judge one another. I alone am judge. So I figure it's between the person who chooses that and God when they meet up at the pearly gates. So I just offer that, and I'm sorry I have to speak out and leave. My husband's texting me. But I wanted to say that on his behalf, because he had hoped to attend your workshop and say, this is what the result in Oregon has been. And Brittany was considered an abuser of the system because she seemed to use it more as a marketing tool, what she was doing, than as a heartfelt thought about idea. Do you understand what I'm trying to say?
I think that's maybe us judging Brittany's.
Well, I understand
choice.
that, but that is the perception of how hers might be different.
But one of her interviews she said, she addressed that. She said, for me, I want people to realize this is my choice. I have pain. I do not want to commit like this, but this is what I need for my life. I think the TV people and the reporters hyped it up more than she wanted it to be hyped.
I think
That was my come away from this week and 2 weeks that I'm looking at that.
For myself, I found that her healthy appearance, requesting to do this was so dramatically different than what I've been used to encountering of who is asking and when had an effect on me also.
So
Kelly?
I feel like as a professional hospice chaplain, I need to clear something up about what Linda said. Actually, as hospice chaplains, I work for a national agency. We have a national policy. I know what it is. Hospice is not allowed to be involved. Our staff cannot even be in the home when people choose to take the medication. So it's, as a hospice person, I don't have to reconcile it. And that's good because theologically, as a chaplain, to me, it's an ethical issue, but ethics and theology are twins. And so for me, it gets back to the consistent ethic of life. And that's also part of the conversation. We want to honor people's autonomy, but as a professional in the medical system, I have a right to my integrity too, and a right to not be involved in things I feel are unethical. And that's where I have to stand as a medical professional, as a chaplain.
Just let me clarify two things. The hospice places I worked were facilities for those who had 2 weeks or less left to their life. And part of our role was, if we were there caring for them and they requested it, we had to, we were asked to convey that to a physician or family member that the person had requested it. And that was our role in it, not to administer, not to do anything. So if we did not feel that the person had, if we didn't feel that that was an option for that person, then we were seen as being a barrier to the person's right to ask and have that information conveyed. That is what the hospice worker's role in it was, and in no other way.
Okay.
Okay.
See, we would only, someone else wants to talk.
You have to come up and honor the question up here.
Well, I wanted to respectfully push back, and you can stay or you can go, that's fine, it's not, but, on a couple of points. One of it is, I will admit, a fear-based thing. I have an anxiety disorder, and I do not want there to be a slippery slope between this law and a new law that says the doctor gets to decide what my quality of life is. And second of all, I go, if you take my anxiety out of the issue, which is usually a good thing to do, so we'll take that out. When you talk about being in insufferable pain and stuff, on a regular basis, 3 to 4 days out of every week, I'm a 10 on a 10 pain scale. That's just my reality. And I'm still here. Does it suck? Yes, but there's way too much for me to do to think of giving up. Now, I don't know if I'm just tougher than everybody else and everybody else is just a wimp. I mean, I don't know how that operates. I don't know people's, but I do know that that is my existence, and it does disturb me that people think that it should be, I'm not trying to take away people's rights, I'm not trying to take away their dignity or autonomy, but it makes me very uncomfortable to think that that could be a reason for someone committing suicide based on just pain alone. And that makes me, again, go back to when do we, if we start at this point, when do we get, because I've studied history, I've studied the whole Nazi Germany thing, and people call me paranoid, which we'll just again leave that out. But when the elections and the Tea Party stuff was going on, and I'll try not to get too much in politics, they were cutting budget programs and stuff. I thought that was the same thing that the Nazis did, just in a slower form. So you're still trying to eliminate me, you're just going to do it quietly and under the... And so I don't see this going down a good road. I see this being the first step to a long step of people finally saying, well, you know what, she's in a lot of pain. Her quality of life sucks, let's end it. Does that, I'm not trying to be paranoid, and you can respectfully tell me if that sounds paranoid.
Your opinion is very valid. You have every right to express how you feel.
Yeah.
Absolutely. And it is, your voice is an important voice in the conversation. Both voices, all voices need to be in this conversation, which is why I brought it here today. Not to go on any one direction or another, not to support one position or another, but to open that conversation because we are not having it in the United Church of Christ.
So I forget your name, I apologize.
Laura.
I totally agree with Laura's comments on the slippery slope, quote unquote, when it comes to this issue. And I've had a couple of individuals facing these. It gets much tougher when they're younger people making these decisions, but that's a whole other story. Well, I guess what my thinking is why can't we, speaking generically here, why can't we dedicate our efforts, our monies to develop or talk about these types of issues when we can talk about broadening our community support? So folks don't have to turn to this decision. Maybe I'm out there when I say that. I don't know, but I have a feeling that I know there's some things that are very unavoidable and very terminal, and I totally I understand that, but I see the death with dignity or whatever it's called as a easy way out for some folks.
I agree that an important part of the conversation is to engage in how do we hold in tension autonomy
Right.
and interdependence.
Right. Yes. Thank you.
How do we hold together community of care with I get to make my own decisions?
Right.
And there is a tension there that we need to hold and respect and explore, but the conversation regularly comes down to either or. We're not real good at holding the both and.
There would have to, for me to be, again, I don't like, same reason with like, you know, with like the issue of abortion or something, that's not something that I like, because again, I go back to, well, what if someone aborts someone like me? But I'm also not going to go around telling other people that they can't do that, but the conversation makes me uncomfortable. So for me to ever be comfortable with this particular law or conversation, where there would have to be a lot of safeguards, and they would have to be very ironclad safeguards. And again, for me to ever get on board with it, I'm not telling other people what they have to do, but for me to be, okay, I can see that assisted suicide is okay in such and such instances, but then there better be, it has to, as it said, and I don't know if all of them have the same laws, what you read about California, or if they're all worded the same way, but you know, it said the person has to be cognitively, you know, to say that I want to end this, it has to have to, like, it could never be, you know, well, I'm tired of, like I can't remember what I read, but there was a case somewhere, and a judge granted a family to end the life of their daughter because she was in so much pain and she had a disability or something. And I can't remember, I don't have an exact quote, but I remember reading that.
And maybe I am projecting some personal feelings on this conversation, so I'm going to try to keep as general as possible. But when again, going back to the young people with disabilities that I know who struggle with these types of things. There are folks who come out of the woodwork calling them brave, and they're how brave you are for making this type of decision. You're heroic and whatnot. And my response, and I apologize if I offend anybody when I say this, is where were you when people were going through tough times that led them to this decision? Where were you when, but going back to your whole interdependence, you said what I said a lot better. Interdependence and the sense of community. Where were you when folks were facing tough times that led them to say, you know what, I just want to end it all because I have nowhere, then I'll finally be at peace.
Mm-hmm.
So that's where my head's at.
Mm-hmm.
I think legally, when I was at the law school in Chicago for a week on the Catholic priest and the Catholic bishop did die. He did die. He had cancer, he did die, but he wrote a letter before he died because he was going to address us. And he was very present for life, but he understood why people would try to understand death, of the pain, the agony, and the defeat of pain. I don't hold a decision. I'm full life, but I understand the issues that is on hand, and intellectually I can understand, but morally I'm really not there at.
How about theologically?
Theologically, John, a priest that was one of my professors said, it is a hard decision. I mean, one of the classes that I had to take was suicide among the family, and it was taught by a priest. And it was very, very ethically confusing.
Mm-hmm.
It was not a fine answer, but it was very confusing. And we felt sorry for the people that had to come to that decision. But going back to the gentleman's comment is, where is the community when somebody is in that state of mind?
Just say that I really appreciate your kind of the balancing act that we've got to do on autonomy and our interrelatedness. I think on autonomy, it's important that we distinguish between a right and an obligation. We can have rights that we never act on. So I think it should never be a situation where someone is put, what the right is that they, as individuals, can say yes or no. And those two options have got to be there for them. And one other factor in this balancing, we need to deal with the confusion. When are we prolonging life and when are we prolonging death?
Correct.
And that's a hard one to sort out.
When are we prolonging life? When are we enhancing life? When are we prolonging death?
Yeah.
Okay? What is, I had it was right there, I lost it.
The opposite of that is prolonging suffering.
God gives free will. Is there a limit to the free will that God gives us when we hold that up against autonomy as well? What is the theology of suffering? How much suffering ought we accept or endure? How do we define and understand suffering? How do we lay our assumptions and definitions of suffering upon others? Remember that healthcare, quality of life, disability paradox I talked about?
Right.
Yeah, I'm on a hospital ethics committee. And it's interesting to me, a lot of people, they will say, oh, there could be a miracle. There was somebody, they lived, in the coma. But they'll be saying that about someone who's brain dead.
Yes.
Now, when you're in a coma, there is a chance that comes in.
Correct.
If you're brain dead, all the controls
Are you
gone.
then in a persistent vegetative
Yeah.
state, and Karen Ann Quinlan, and all of those cases that have influenced
Yeah.
us along the way?
So we can keep the air going, we can keep the heart pumping.
Yeah.
But if the brain is dead, it's never going to be our doing it.
Right.
Quinlan's case was that she did not see any hope. She was not dying. She was on a hunger strike. And the hospital had to travel to another hospital because she wanted to die. But she did not die. She came back. And I don't remember if she had a born again experience to bring her back. I don't remember. I mean, that's been 30
Quite some time. Yeah.
that's
It's been a long time.
37 years ago. And that was the end of the case. The other case was 5 years ago, 6 years ago, when Congress makes the decision about the cure for some of the F. The cure case, that was never into the case, and the government got involved with it and made that decision for them.
The government got involved and made the decision for them.
Yes.
See?
But
That's
the government.
Just
got
hold
involved-
that for a moment.
But they got involved at the request of the patient's family, so I want to make sure that being a healthcare provider,
Uh-huh.
that we also remember that there are theological, ethical, and medical,
Absolutely.
let alone legal issues that play on the role of healthcare providers.
Oh,
And
yeah.
not all of us are on that negative spectrum. Many of us are advocates, but we, again, also walk a fine balance.
What we like to talk about as moral distress and or moral injury in the provision of health care.
Yes.
Correct.
Right,
Absolutely.
very much.
But you bring and Laura and Paul bring a good point that there are so many voices that need to be at the table, and I think we also need to remember, and I'm not gonna say it as eloquently as Valerie did, but I see you and I respect you
Yes.
at that point. And I don't think we all bring that when we come to our medical ethical conversations all the time.
Mhm.
Well, I think it's really hard to do that in the healthcare system.
It is.
Because it's so fast paced and I live in a big city, so, it's hard to not be a number in the medical system for anyone, and.
I think everybody's truly passionate too
Right.
about the majority of people, I think, are truly passionate and wanting to help the people that we are assisting or caring for or in the health arena with, and so then it's hard for us all to keep ourselves quiet.
Well,
I don't know, I'm gonna challenge that.
Well, I should say in where I am. I think
Yeah,
everybody
well,
is
as
doing
a
that.
person with disabilities, and a person who works in the medical field, I have had some firsthand really bad experiences with nurses and hospital staff.
yes.
Because when I went to do my residency, I was basically told there was a rumor going around the hospital that went all the way to the hospital administrator that my speech patterns indicated a developmental delay and I was therefore unqualified to be a chaplain. Now, no one in that hospital actually had that diagnostic medical proficiency to make that diagnosis, but that did not prevent them from doing it. It did not prevent people from making judgments during rounds and passing on report about people with developmental disabilities or things like that. So it's very much a live part that's not written in the charts, but a very much live part of the medical community that does this person-to-person ableism. It's very real.
And going back to some of those, I'm sorry, going back to some of those safeguards that people have talked about in legislation, going off of Kelly's part, not all physicians get disability. So the fact that there still has to be 2 physicians in Oregon, that doesn't help me sleep at night by any means. Because if it's 2 doctors that don't get it, I use air quotes, but don't get it, that doesn't help. That doesn't help me any.
What is the scope of knowledge?
Right.
And interest or openness
Correct.
that the physicians have had. You were talking about how people are viewed in the hospital system. I wrote an article, it was published in Plain Views, which is a journal for healthcare chaplaincy, Patient Experience and the Language of Disability. Because it's all about patient experience in the healthcare world today. So, how do we use person-first language as a way to open up and begin to value the person, very similar to what Valerie was saying, right, in the healthcare environment, by not referring to John, not the MRDD patient in room 2.
Right.
I was doing a physical one day for a camp that I was on staff. I've been on staff for many, many years with this camp. But by law, they need to have physical 5 years. I went in, I've been doing consulting stuff for many, many years at a camp. And the medical doctor excused me and told my supervisor that I was not equipped to work with young people because of my disability. And that happened 20 years ago.
Oh.
An issue that may be coming down the road too is the role of money.
Yes.
Then take, for example, the guy who brags about buying $9,000 bottles of wine, took over a company, jumped the price of a medicine that is for
The
people.
$30 to $900
Yeah,
medicine store.
4,500 and some percent. Will that start happening? And really, by that kind of lifting of, that's going to exclude certain people from getting life preserving.
And then how does rationing factor into that as
Right,
well?
Yeah.
Well, and the other issue too, talking about patient satisfaction, as we all know, Medicare reimbursement now is based off of patient satisfaction. And the only people who complain, speaking generally here, are the people who have bad experiences.
Right.
So if you don't fill out that survey that you get 6 weeks later, or you fill it out negatively, then your local hospital is going to see a reduced Medicare reimbursement.
Correct. Correct. So decreased revenue
Right.
is not necessarily going to improve the healthcare system.
No.
It is not, decreased revenue and volume is not going to improve the delivery of health care. And reimbursements are becoming more and more tied to survey results. So revenues are tied to survey results. You mentioned your ethics board, and I will tell you that on my ethics board, we do not have yet a person who self-identifies with a disability. I asked, do you have a person who self-identifies a disability on your ethics board? To raise that voice.
I will raise that question.
Because that's a recommendation that I have in my conclusion, is that we begin to think about who is not at our tables in these areas of healthcare disparity.
Yeah, exactly.
Yes.
Gunnar, I don't have all the answers. I'll preface my comments with that. But,
Darn.
but I know a huge percentage of healthcare dollars are spent on the last couple months of life too.
Yes.
And I asked myself, how did we get into that type of situation? There was a study at Duke that showed that folks who have a self-professed religious or spiritual background who felt that their spiritual needs were being met were satisfied with a much lower level of health care than people who felt their spiritual needs weren't being met in the healthcare system, and their healthcare dollars expenditures were much higher. So I think there's a significant bit of information there about how to best deliver healthcare, but it also comes back to, who is that person who's receiving healthcare's community? How is the communication and dialogue in that community? I know in my family, my grandmother received a lot of healthcare in the last few months of life. I walked in with a clergy collar on, so they didn't know who I was, and the nurse was saying, why is this family putting this woman through this? And she was getting health care that she probably shouldn't have. But there was no one helping my family through that to understand, okay, here are your options, let's have this discussion. So we have to look at how people work together across different barriers.
I have one more thought. An 85-year-old woman went into a home. A month later, her killer gave her and second got a bill for a drug. She'd never been on a drug in her life. When he came to approach them, and they said we had to shut her up. So we had to medicate her and keep her quiet.
We have 3 minutes. Conclusion. What do we do? What do we do? Where do we have the conversations? What is our role? I think there's a role for advocacy. I think there's a role for us to have these conversations in our congregations, in our communities, a role for the congregations, our congregations, to open up community forums to begin to discuss these issues. I think there's a role of advocacy in the hands of justice, witness ministries, etc., to get into legislative actions and make sure that the voice of persons with disabilities is raised, to be heard before legislation is enacted that increases disparities and stigmas. And I think that's our responsibility to begin to call for that. So that's all I have. That's all the time I have. And I give you 1 minute before lunch.